Alrighty. Well, Dr. Newhouse, I'm going to pass it off to you. We'll go ahead and start with the first slide.
Thank you, Kiara, and welcome everyone to this Midsummer 2026 update on our studies of the treatment and prevention and neurobiology of Alzheimer's disease in our friends with Down syndrome. Um, Many of you and your families and your loved ones have been participants in the trial ready cohort Down syndrome study that we've been running now for several years. We're very excited to give you guys an update of where we've been, where we are going. There's a lot of excitement in this area. And as Kiara said, I'm going to just review some basics on this and then set the stage for Doctors Conley and Wilson. Dr. Conley will talk about the specific research that we developed here at Vanderbilt that's going to make, I think, a significant contribution to our understanding of this problem. And then Dr. Wilson will specifically talk about the therapeutics and prevention studies that we are part of nationally and internationally to make an impact on this disorder. So let me just review a few basic facts about Down syndrome and brain aging. John Langdon Down described the syndrome in 1866. The diagnosis was made clinically by essentially looking at someone until 1959, when the chromosome abnormality was reported by Jérôme Lejeune in France. The incidence is about 1 in 800 live births, and over 350,000 people in the United States have Down syndrome. The name Jérôme Lejeune you can keep in mind because I'm going to come back to that closer to the end. Next slide. Kiara, there we go. So as I'm sure you're all aware, or many of you are aware, Down syndrome results from something called trisomy 21, which is an extra copy of chromosome 21, and it's illustrated here in this karyotype with a box around the 21st chromosome. And you can see in this particular individual, who is a male, by the fact that they have an X and Y chromosome, there's also a third copy of 21. And so this is the defining sort of biological driver of Down syndrome. If we can just go back a bit, yeah. And usually there's an entire copy of the chromosome, but there can be variants as well with either part of the chromosome duplicated, or even a case where you can have some cells that have the trisomy 21 and some cells in the individual that don't. That's a pretty rare form that we call mosaicism. Next slide. One of the things we have learned really since the 1980s is that individuals with Down syndrome, unfortunately, are at increased risk of developing Alzheimer's disease. And because of this, if they do develop Alzheimer's disease, they develop it about 20 years earlier than the rest of the population does, the neurotypical population. So for those of us in the neurotypical population, we might become symptomatic in our 60s, 70s, and 80s, but our folks with Down syndrome may develop cognitive impairment as early as their 40s. And so it seems to be that the whole sort of neurobiological process is shifted earlier 20 years. And in this figure by our colleague Juan Fortea, who's in Barcelona in Spain, he has shown what these different biological markers are essentially of the developing Alzheimer process. And he has argued that we could begin to see some of the earliest biological changes as early as the teens in patients with in individuals with Down syndrome. And in fact, the new diagnostic criteria implies that people with Down syndrome are Alzheimer's stage 0 because they have this genetic risk. It's similar to the individuals that have something called autosomal dominant Alzheimer's disease, where there is literally a genetic mutation in those families that causes them to develop early onset Alzheimer's disease. Next slide. As I suggested, if you look at this plot on the right side of the screen, you'll see the folks with Down syndrome in yellow and the folks who are neurotypical in blue and red. And you can see this time shift, right? So individuals develop Alzheimer's disease, or the percent that develops dementia due to Alzheimer's disease seems to be shifted to the left and is about 20 years earlier than those of us who do not have Down syndrome. So the average age of onset of frank cognitive impairment is in the early 50s. And we believe that basically everyone with Down syndrome over the age of 40 will show some brain abnormalities characteristic of Alzheimer's disease, even if they don't have any symptoms as yet. Next slide. Now, one of the things that's interesting about that 21st chromosome, the triplication of it, is that unfortunately the chromosome 21 carries many genes that appear to be associated with Alzheimer's disease, even in the normal non-Down syndrome population. And so the biggest one here is this one highlighted in yellow called APP, which is amyloid precursor protein. That is the protein that drives Alzheimer's disease in everyone, whether they have Down syndrome or not. And it does appear to be the earliest biological marker of this disease. And we also believe that it is the best target for early therapeutics. Now, that being said, you can see there's a whole bunch of other sort of identified genes on this chromosome that we think are linked to Alzheimer's disease. We're not sure exactly what the contribution of those is to folks with Down syndrome, but we believe that overexpression of these genes is probably not a good thing. Next slide. Now, if you look in the brains of people with Down syndrome who have dementia, they look neurobiologically virtually identical to patients who have Alzheimer's disease later in life who do not have Down syndrome. And so we see all of the same amyloid plaques or amyloid pathology, as well as the neurofibrillary tangles. And the plaques and tangles are the hallmark of Alzheimer's disease. And so under the microscope, these things look very, very similar, and we believe they're functionally equivalent. And the good news about that is that means that therapeutically, we can use similar strategies to target prevention or treatment in folks with Down syndrome. Next slide. We can also see this in brain imaging, and here are some very early studies showing you that we can see the two major types of molecular pathology even without getting a microscope out or looking at autopsy samples. So we can see amyloid, the high levels of amyloid using something called amyloid PET imaging. We can also see high levels of neurofibrillary tangles using something called tau PET imaging. And many of your loved ones have participated in these types of scans as part of the TRC-DS program. Not everyone has gotten these scans, but particularly the early participants have. And if you've been part of our local effort, you would have received amyloid PET for sure. Next slide. Now, just a reminder about the trial-ready cohort Down syndrome program. This is part of something called the Alzheimer's Clinical Trials Consortium Down Syndrome Program, which is a clinical trials platform to prevent Alzheimer's disease in people with Down syndrome. And it's an international consortium. Right now, there are 15 sites, but there are actually being more added all the time. There's now a site in France, and there's going to be additional sites in the United States as well, covering large areas which don't have any coverage at the moment. You can see us here in Tennessee. We are one of the original sites. And so this is a rapidly expanding program funded by the National Institutes of Health Include initiative, which was designed to bring people with Down syndrome into research studies in Alzheimer's disease. Next slide. And the trial-ready cohort is exactly what we intend it to be. We hope folks will be pre-qualified to participate in many of the treatment programs that we are now initiating. And so this figure is from a few years ago and was started before we had any of these treatment studies. But we have been building this cohort over the last 5 years or so, in our case, mostly through direct recruitment. And then the goal, of course, was not just to study them and follow them, but more importantly, to actually offer treatments that might offer the opportunity to reduce the risk of developing Alzheimer's disease and dementia as we move forward. And so you can see here, there was a plan to be at least 3 clinical trials, and that is where we're getting to at this point, and Dr. Wilson will talk about that specifically. Next slide. What we've been doing here at Vanderbilt as a complement to the TRC-DS studies is we've been very interested, along with our colleagues here at Vanderbilt and also the director of the whole TRC-DS program, Dr. Mike Raffi at USC, is we've been very interested in something called the cholinergic system. And the cholinergic system is a system of nerve cells in the brain which send out projections all over the brain. And we know that this system is very impacted by Alzheimer's disease pathology. We know this from studies going back almost 50 years in patients without Down syndrome who develop Alzheimer's disease. And we know that these nerve cells, particularly in these little clusters here, are very vulnerable to Alzheimer's disease pathology. And so we've been interested in seeing if we could develop new methodologies to understand, is this also true in people with Down syndrome? And so that's what we've been focused on here. Next slide. And one of the ways that we've been doing that is using something called cholinergic PET imaging. And this is a study, again, that many of you on this Zoom call today have participated in, where we were funded by the NIH and the National Institute on Aging and the Alzheimer's Association to develop this particular radio tracer that images the cholinergic system's integrity in the brain. And we collaborated with our colleagues at the University of Michigan to develop this tracer here. They were the original site that developed this, and we were able to get that going here and get it synthesized. And we've been able to get some really fascinating information on how the cholinergic system changes, or how it might change in Down syndrome, how it might be different from folks without Down syndrome, and then tantalizingly, how we might be able to use that to track the treatment effects over time. And Dr. Connolly is going to explain this in much more detail. So I think that's my last slide, but let's go ahead one more. Yeah. So in summary, if we can back up just one. So in summary then, we've come a long way over the last decade in our understanding of Alzheimer's disease in people with Down syndrome. We still, unfortunately, are about 5 years behind the rest of the Alzheimer's disease field in our ability to treat this illness. You may be aware that there are now new disease-modifying therapies available for patients with Alzheimer's disease. We're not there yet with Down syndrome treatment, but that's exactly where we're going now. And so we hope to remedy this situation by getting these studies launched, and we are eternally grateful to everyone on this call and all the participants and their families for their trust in us and for collaborating with us on this journey. We could not do it without you. So with that, I will save questions until the end and turn this over to Dr. Conley.
Well, thank you, Dr. Newhouse, for that overview of both Alzheimer's disease and its impacts in adults with Down syndrome. So if you go to the next slide, Kiara. So this is once again a synopsis of our own study, which was taking people who we recruited here for the main TRC-DS study and doing that initial investigation there, and we really wanted to dive deep into that cholinergic system. And if you go to the next slide, Kiara, why are we interested in the cholinergic system? It's involved in two big areas that decline with the development of Alzheimer's disease. That is memory and attention, two things that often seem to lapse with the development of dementia, as well as it's helpful in sort of clearing out some of the plaques, or is thought to help with clearing out some of the plaques as well within the brain. So if you go to the next slide, Kiera, there's been some work once again from our colleague Juan Fortea in Barcelona, looking at sort of just the volume, the actual structural size of the basal forebrain, and sort of what it does in adults with Down syndrome across the dementia spectrum. So as you can see on the figure on the right and the top side part of the figure, you'll see these declining curves with aging, and the different colors there are blue are the people who are considered they do not have dementia at this stage, adults with Down syndrome without dementia, but the red dots are the people who do seem to have adults with Down syndrome who do have dementia. And you can see on the bottom, just looking at those volumes, how when we go from the blue to the red, there is some decrease in the volume of that area. But what we really want to do is look at function. So if you go to the next slide, Kiara, this is that FUBV, that cholinergic PET. What does it do? It's a dye that we use that attaches to a little transporter within the brain, and it allows us to sort of map the function of the cholinergic system. So Kiara, if you could just click a button. Great, thank you. You preempted me, and as you can see on this figure here, you can see that the uptake or the binding of that dye is from the healthy control to from mild dementia to later sort of Alzheimer's disease dementia. We see reductions specifically in the sort of cortical areas, so the sort of higher part of the brain, which is often involved in some of these higher order processes, and so we sort of see that declining. So again, this is in adults without Down syndrome. But we want to use this, and we have been using this for the past few years, and we want to say what is different, or is there a difference between how people without Down syndrome and people with Down syndrome respond. So if we go to the next slide, the other thing that we're very interested in looking at is sort of another marker of cognitive function, which is the other thing that we did during these visits, which many of I will know, remember me putting the net of electrodes on people's scalp. And what this is called an EEG or electroencephalography, which records from a number of electrodes across the scalp. And it sort of takes a map of brain activity at once. And if we look at taking that brain activity, what we can do is we can isolate different processes. So in this little figure here, um, we're looking at what's called a visual oddball effect. So that's when you get a lot of um, the same stimuli. So this is yellow dots, but if you see a red dot, which is different, does the brain respond? And we can look at that and say, yes, the brain does respond a little bit differently. So that's some of the different sorts of probes that we're using to sort of look at cognitive performance um, with our adults with Down syndrome. So coming back to that study design, we're taking the majority of our people were from the main study from 25 to 55 years. We also recruited some people who were a little bit younger from 18 to 24. And that big white box is the main thing that we're doing differently to the main study, including that cholinergic PET and the EEG and a little bit of actigraphy, but we're not going to touch on that probably for the purpose of this talk. So why are we doing this? Once again, we want to look at the cholinergic system. And the nice thing about partnering with the TRC-DS study as a whole is that we're not repeating more measurements than we would need to. So it's really helpful to be able to partner with them. So we're really grateful to work with Dr. Raffi to be able to partner and sort of work with him. So once again, those sort of key questions, we want to look at this system. It's involved in the development of dementia. How does it differ in adults with Down syndrome, sorry. And also, does it interact with this amyloid protein, this protein that's normally something that is quite helpful, but in dementia sort of misfolds and becomes junk and can become toxic? How does that relate differently with the cholinergic system in adults with dementia compared to neurotypical adults? And also, does it affect sort of these markers of attention and memory and processing that we can see using those EEGs? So that's our general idea, and I want to get into those results now. So one thing that you want to do in terms of looking at the results is compare to another group of adults. So we were using um, age match controls with our colleagues at the University of Michigan to compare because they've got a lot of this cholinergic PET data. We have some as well, and we were able to combine a cohort. So we have people of similar ages who have Down syndrome and who do not have Down syndrome. And then from a group of our own participants from a different cohort, we sort of looked at matching on the level of that amyloid protein within the brain that we can see using PET scans. So this really allows us to sort of get closer to do a more even comparison. Okay, so what do we find? So let's go to the next slide, and I want to break this up into sort of the three different areas. First, that age matched analyses, then looking at the amyloid matched group, and then finally I'll talk about some of the EEG work, which is very new that we can talk about a little bit. So if we look at that age-related data, so this is looking at just that PET scan between people of roughly the same ages. So that cholinergic binding. So this is the activity, the uptake in the cortex. On the left, you can see an actual image from our participants. So this is an average image of the uptake within our adults with Down syndrome. It sort of mirrors those images that I showed you before from that previous paper. But what you can see on the right is looking at a comparison of a number of different brain regions. And even if some look small differences, by and large, we actually see higher levels of this cholinergic uptake within the adults with Down syndrome compared to their age-matched controls. If we go to the next slide, Kiara, what's very interesting with this is though there's a change with age. So if you look at this, now this is well, I'll say these are all people who have the scan once, but people who are younger, who are adults with Down syndrome, tend to have higher levels compared to their neurotypical cohorts, but that difference shrinks over the aging period. So they tend to follow opposite trajectories, which is really interesting for understanding how the disease develops within the different populations. So we're very interested in sort of teasing out and exploring what is this difference in relationship to the Alzheimer's disease process, which leads us into our second analysis stage. So this is looking at the difference, looking at that cholinergic uptake, so the system versus the plaques or the cause dementia. So looking on the right of this image, you can see that we see this is again an average of the participants we've recruited for our local study. You can see the level of sort of amyloid that we see within the brain. It tends to be relative. We didn't have many people who were um, uh, in that higher level of amyloid positivity, but there is still some level of amyloid, which we all have a little bit. But on the left, what you can see is something very interesting is again, the curves between the people who are at the same level of roughly amyloid on the non-adults with Down syndrome and the adults with Down syndrome, they differ. Now, these graphs are a little bit different. So instead of looking at an age, we're looking on the y-axis on the amount of cholinergic binding versus the amount of amyloid in their brains. And people show different trajectories depending on the two groups, and this is really interesting and something that's never been seen before. And we're really interested in teasing out and exploring this relationship. And so it may just be that, as Dr. Newhouse was mentioning, because they're further along on that time course in terms of developing that Alzheimer's disease earlier, that might be driving this relationship difference. But it's something that we're not fully sure of, and something we want to keep exploring. And I'll talk about it a little bit more in a moment. So one other thing that we saw in relation to those amyloid plaques is that a lot of the paper and pencil tasks that we do with the TRC-DS study, so things like the Down syndrome mental status exam, the cued recall task, and the Stroop's cats and dogs task, were actually related with better performance of that cholinergic marker. So if you're having more of that cholinergic system in your brain, and sorry, Kiara, could you go back a slide? If you have more of that cholinergic activity on the brain. So in that in those plots on the left, you're higher on the y-axis, you tend to perform better on those different tasks, which again is really encouraging and actually sort of follows this relationship quite closely. So finally, I'm going to talk a little bit about some of the results we saw with the EEG and then how that relates back to some of the cholinergic, the Alzheimer's disease processing. So one thing we did with the EEG tasks, one of them we did was called a passive memory task or an incidental memory task. And essentially what we would do is we would present a series of images which is on the top left that you can see. Some of them repeated, some of them were only presented once, but we didn't tell anyone to sort of focus on those images. All we told people was to respond to that smiling face, which is why it's called a passive memory task, because this comparison is not explicitly stated. What you can see on the right is heat maps sort of reflecting brain activity. So these are from different areas, from left to right. We go from the frontal area, sort of the central area, and then at the back of the brain on the furthest to the right there. And these are the two different types of stimuli. So on the top, it's that novel stimuli you only see once. On the bottom, it's those repeated stimuli that you see multiple times. Now, the boxes there are actually indicating significant differences in processing just between those two different trials. And we wanted to have a look at, okay, we found a task effect is what we call, and what does that task effect in these different areas, and these are denoting sort of the amount of activity of nerve cells at any one time, how do they relate to these amyloid proteins? So these proteins that cause dementia in the long run. And what we found, and the next slide, is they actually relate to a lot of different areas in the brain, and specifically over the back of the scalp. So that furthest to the right in the last area, we actually saw a relationship between the amount of increasing amyloid on the y-axis and a deficit in terms of response processing, in terms of that um, band of power, what we call the theta band, which is important for sort of visual attention. So it does seem that we can identify an interfering aspect of this increasing toxic junk protein on sort of visual processing, and it sort of is creating some level of interference. So those are some of sort of the in some sort of the I guess the top line of different things we've sort of seen so far within um, our local cohort of adults with Down syndrome from the TRC-DS, as well as a couple of others from outside of TRC-DS, that we do see a differing relationship between the control, the adults without Down syndrome and those with Down syndrome. And it does seem to be in the opposite direction, which is really interesting and something we want to tease apart. But if you go to the next slides, Kiara, what I do want to say that they're novel and interesting, but they are just a snapshot in time. And with a lot of data, it's that single snapshot is incredibly interesting. But if we can look potentially longitudinally, so doing an additional session of some of these measures, then perhaps we can look at changes in trajectory across time. And that's something that we're very excited to announce, is that we were funded recently by the Foundation Jérôme Lejeune. So it's a French foundation of looking at doing research, care, and advocacy. And what that was, if you could click the press the button, Kiara, was to do a repeat um, of these cholinergic scans and EEG scans at roughly sort of 2 years following that initial scan. So this is sort of what one of the things we're really excited to talk to you about, and we really want to sort of talk to all of our participants who have been a part of the first wave to sort of see and talk to them about sort of joining us for that next wave. So and there's a couple of reasons behind sort of why we want to really explore these changes. So if you go to the next slide, Kiara, why are we wanting to do this? Well, we've taken that initial snapshot. We sort of see people on different trajectories. But what happens with time? Do the trajectories stay the same? Do they differ? That's something we're hoping to investigate. Similarly, the relationship with amyloid. Does the relationship with amyloid and this cholinergic system change with time? And we can hopefully we'll be able to compare these two things longitudinally with our sort of neurotypical controls that we're doing at the same. We're hoping to do some longitudinal scans with them as well, and then we can sort of compare again very reasonably close comparators, and we can sort of see how these different groups change within time, which is going to be really important for understanding how the system changes with the development of Alzheimer's disease and Down syndrome. So we are really excited to invite all of our participants who were so instrumental in this initial wave to be part of the follow-up study. And we're really hopeful that this could help with the new phase of sort of designing new sort of clinical trials and other sort of research studies that can test the effectiveness of these new treatments that Dr. Wilson's going to talk about in a moment. So very, very excited to do this in the coming couple of years with you all. And once again, as Dr. Newhouse said, we are very much in all of your debt for your being a part of this study so far, and we are very grateful for for the participation and everything, and everything that you all have contributed done to contribute to this research. Oh, and this it takes a village to do this sort of work. So I just want to thank everyone, both at VUMC, at the CCM, radiology, clinical radiology, neurology, and then all our collaborators at ATRI, at the University of Southern California, Michigan, and the University of Vermont as well. And and Dr. Newhouse and I said before, these are sort of our funders who we could not do this work without. So with that, I'm going to stop, and we can transfer over to Dr. Wilson.
Excellent. Well, thank you, Dr. Conley. It's really a pleasure to be with you all tonight. I'm Joellen Wilson. I am a psychiatrist. I run a clinic devoted to caring for the psychiatric and cognitive needs of adults with Down syndrome. And it's also my honor to be partnering with Dr. Newhouse, Dr. Conley, and other investigators in the Center for Cognitive Medicine to make clinical trials available to our friends with Down syndrome. In particular, I want to talk just a few moments, and I'll keep this brief so that we have enough time for Q&A, but I want to talk just a little bit about the future of Alzheimer's disease research in Down syndrome. So, as you all may be aware, to qualify for a clinical trial, whether it's a clinical trial for Alzheimer's disease or any other clinical trial, that process is lengthy. There's oftentimes different imaging scans that Dr. Conley and Dr. Newhouse have talked about, PET scans, blood work, physical exams. And the same is true for our clinical trials that I'm going to talk about here in just a moment. I think some things that are exciting and on sort of the fringe, coming to the forefront of Alzheimer's disease research that's being made available to our friends with Down syndrome is that there are new plasma biomarkers, so blood biomarkers, in particular p-tau217, which may replace early screening amyloid PET for individuals with Down syndrome who might want to qualify for a clinical trial. So I think we're starting to inch towards maybe having a blood-based biomarker to screen for elevated amyloid in individuals with Down syndrome. So that's really exciting. And one of the things as a clinician as well, so I'm a researcher, but I'm also a clinician, and I care deeply about recognizing early behavioral signs of developing Alzheimer's disease, treating and managing those as best we can. And one of the things that I'm starting to do with my patients is screen them early for early behavioral and cognitive changes. And the the body of evidence is starting to shift us towards screening for early Alzheimer's disease pathology starting around age 40. And so for patients and families that are interested in early screening for Alzheimer's disease and Down syndrome, we may start with a p-tau217. All right, next slide. The therapeutic landscape for Alzheimer's disease or Down syndrome associated Alzheimer's disease, in my opinion, is very bright. I think we're headed into a new era of therapeutics and potentially available treatments to hopefully one day prevent Alzheimer's disease and Down syndrome. While there are currently no approved drugs for Alzheimer's disease, dementia, and Down syndrome, unlike the neurotypical population. So you may have heard of some of these disease-modifying therapies like lecanemab or donanemab, these monoclonal antibody infusions that are starting to get a lot of traction. And you may even know some people that are on those therapies. While we don't have currently approved drugs for Alzheimer's disease and Down syndrome, there are some therapies that can help improve certain symptoms like early cognitive changes, early behavioral changes. So cholinesterase inhibitors, memantine or Namenda for behavioral changes. There are other things that we can do to symptomatically manage early behavioral and cognitive changes. But I think, is early hope in terms of available therapies that may be coming down the pike. So you're on this call because you're likely an advocate for a loved one with Down syndrome, and you may have heard of some of these studies, like the ABATE study or the hero study, Aladdin or Less AD. And I'm going to talk about some of those in just a moment. Next slide. So you all know, I think probably everyone here probably knows about TRC-DS or the trial ready cohort for Down syndrome. It's already been referenced many slides over. So I think I will probably skip over this because we've already reviewed this. Okay. So this is essentially the trial-ready cohort with the goal in mind of sort of deep phenotyping, understanding the clinical, cognitive, and behavioral characteristics of individuals with Down syndrome, and to better appreciate who may be a good candidate for a therapeutic clinical trial when one becomes available. So the ABATE study is one study that we've actually enrolled a participant into. We were hoping to enroll others, but they did stop enrollment for the ABATE trial. This was using a novel vaccine mechanism to stimulate the individual's own immune system to create antibodies against amyloid. So really harnessing one's own immune system to fight amyloid. While the intervention has been safe. Unfortunately, it does not appear that the vaccine itself was stimulating enough antibodies to really fight the amyloid buildup that's happening in the brains of individuals with Down syndrome. So they have paused enrollment on this trial. I'm hopeful that perhaps down the road there will be another version of this trial with perhaps a more effective vaccine target. The Aladdin study is a very promising study that we're about to start enrollment for, likely early this fall or late summer. So we do have IRB approval, we've finalized contracts, and we will start enrolling into the Aladdin study here over the next couple of months. So next slide. And then there will be future studies, and I'll allude to that in just a moment. Next slide. So I've talked briefly about ABATE. Because we're not actively enrolling into ABATE, I'm going to skip over this one because I've already referenced it. Next slide. Okay, so the Aladdin study. So the Aladdin study stands for Amyloid Lowering for Alzheimer's in Downs with Donanemab Investigation. So this is the first study, to my knowledge, that is going to make a disease-modifying therapy, so one of these monoclonal antibodies, donanemab, it's going to make it available and we're going to test it in the Down syndrome population. So it's a phase 4 clinical trial. It's double blind, placebo controlled. And the purpose is to evaluate the safety and efficacy of donanemab, hopefully to reduce brain amyloid. So that's that protein that's building up and causing Alzheimer's disease when compared to placebos in adults with Down syndrome. The study will plan to enroll 60 at all sites. We're hoping to get at least 10 of those here at Vanderbilt. To be eligible for the study, you have to have Down syndrome, age 35 to 50. There has to be evidence of elevated amyloid, and there are different ways that we can screen for that. They have to have a study partner who's willing to engage in the study procedures with them. The duration is 12 months of active treatment, followed by a 12-month open label extension phase. Okay, next slide. Okay, that's the last one. Can we go back two slides, Kiara, where I mentioned one more future studies? Yes. Okay. So I wanted to mention that the ABATE study and the Aladdin study are just two of what I anticipate will be a whole new phase of research where there will be lots of new therapies available for individuals with Down syndrome who we know are at elevated risk for Alzheimer's disease. So there's at least one other study that we will likely begin enrolling into this fall. It is a small molecule that will be intrathecally administered. So what that means is it will be an injection into the spinal column where we inject directly into the CSF a drug that crosses into the blood-brain barrier and will likely downregulate the production of amyloid. So it's a promising, completely novel mechanism that will target that elevated amyloid and hopefully reduce its production. So we're looking at lots of different ways to fight amyloid and to fight the development of Alzheimer's disease in this population. There will be other therapeutic studies with other novel interventions down the road, and I'm happy to take any questions here in just a moment. Okay, I think that's it. Thank you, Kiara. And I
So
think now,
let me jump in, Kiara, for a moment. So what you've heard hopefully will give you an overview of where we've been so far over the last several years. We've made enormous strides going from 0 trials in patients with participants with Down syndrome 5 years ago to the point where we now have some very exciting studies moving into this field, moving into preventing Alzheimer's disease in patients and individuals with Down syndrome. And so that's really very exciting. The work that we've done here at Vanderbilt hopefully will contribute to that effort, both in identifying new targets for investigation, new targets for tracking the potential of positive, hopefully, we hope, positive effect of these new treatments on the brain, and offering new targets for therapeutics. There are other exciting things that are being developed for the cholinergic system as well, new drugs, new mechanisms we haven't had a chance to talk about here, but we're very excited about it, and we look forward to continuing our work with you. So hopefully this has been helpful, and we're here to answer questions, as many as you would like to pose to us.
Yes, feel free to type them in the chat, or you can unmute yourself and just ask the question as you like. So the floor is open.
I see a few people unmuting themselves. Yeah.
Here we go. My question is, do we contact you, or do you contact us to sign up for the next stage?
Either way. So it would, if you reach out to Kiara, who is our point of contact for this, she will be happy to facilitate that, Tom. But if you would like us to reach out to you directly, I'm sure we can do that.
Okay. All right. Thank you.
I think we had a question about NIH funding. Well, that's a kettle of fish for sure. NIH funding has been very challenging over the last year, as many of you can imagine. It hasn't directly affected our work here on Down syndrome as yet, but and we are very pleased to be able to report to you that the Include initiatives, which really started this whole process of including people with Down syndrome and Alzheimer's disease research, those Include initiatives have just been reissued. So that's very good news, because for a long time over the last year, they had expired and NIH was being prevented from issuing new or renewed requests for applications. But I am pleased to report that they have relented, the administration has relented on that, and now we have the Include initiative refunded. So that's very positive.
There is a
So
question.
at this point, I would say that NIH funding is, we keep being hopeful about it. And there were a couple of other questions in the chat. If you could read.
It looks like Marianne asked, since my son is 54 and has Down syndrome, are there further, I think, studies he could participate in? Potentially. So some of the, he could potentially qualify for Aladdin if that's something you're interested in. The other study, which I can't name yet because it's not finally approved, will enroll individuals with early stage Alzheimer's disease. So in order to understand better if your son or daughter might qualify for a study, please contact Kiara. You're also welcome to email myself, and I'll put my email in the chat, and we can we can chat with you about your loved one's eligibility for a study.
And someone asked, Beverly asked, is there any way to find out our child's p-tau 217 number? So that would be, we would obtain that as part of screening for a trial. And we would be able to share some of that information with you, is to be able to do that. And I don't know that we have that information yet from TRC-DS. I know we are doing some disclosure of some biomarker data in TRACK-DS, but I'm not sure if p-tau, I don't believe p-tau 217 is part of that yet, but we would obtain that as part. Are we able to have it done with a local neurologist? The answer is possibly, although you might have to pay out of pocket for it. And we actually don't know fully how to interpret that number yet, because this is early days with these blood-based biomarkers for folks with Down syndrome. And somebody else says, I was contacted with another round and told we would get a report. Yes, that's right. We would be able to give you a report. Those reports have just recently been authorized by our IRB nationally and our institutional review board nationally, and we are in the process of preparing those reports, and we're happy to sit down and go over that at the next available visit. So yes, we can give you a report. It may not have everything, but it will have a substantial amount of information. Keep in mind of inclusion of criteria with adults with cochlear implants, since more of our adults are obtaining them. Yeah, this is a very important issue. And here's the rub with cochlear implants. It's very hard to put them in an MRI scanner with a cochlear implant. And unfortunately, we have to use the MRI scanner for safety reasons. For these anti-amyloid treatments, because there is the risk of what we call brain swelling, or ARIA is the term that we use for all of these antibodies. And so we do have to use MRI scanning just to check for safety purposes, but that's really hard to do in people with cochlear implants because there's metal in there and it might damage the implant and or the person having the implant. So do discuss that with us if your loved one has a cochlear implant. There may be some workarounds, but I can't guarantee it. Dr. Wilson, you may have more information on this.
Yeah, and some of the newer ones are MR safe. Most of you, if your loved one has a cochlear implant, may have a device card that has the specific model information of the cochlear implant. That information is very helpful for us, and we can usually speak with our MR technologist and appreciate which devices are safe to use in the context of an MRI.
There you go. Great. All right. What other questions can we have?
I've got one. Let's see. To participate in the study, our son had to take a medicine every morning to keep his thyroid level, I think, below 4. Don't have the details. My wife took care of all of that. But having finished the study, his physician said it wasn't necessary to continue that medicine because it was still under 5, or it had to be brought down for the sake of the study, but otherwise it was in the range of acceptable, So
Mhm.
what do we conclude about that? Would there be an advantage to continuing the thyroid medicine?
Dr. Wilson, you want to handle that?
I'm not sure which study this was for. Was this for the trial ready cohort, the TRACK-DS?
I think so.
Yeah, okay. Okay. Um, so that's a great question because we do know that autoimmune disorders in particular autoimmune thyroid disorders are very common in Down syndrome. A lot of the new therapies that are being developed do target the immune system. So many of these studies do require stably treated thyroid disease. So if someone has thyroid disease or another autoimmune condition, that those are being stably managed and treated. I'm not aware of a current research protocol that requires it to be below a certain point, like the thyroid stimulating hormone
Hmm.
level to be below a certain threshold. Um, but that's a good question.
Yeah, my guess is that as long as it's sort of considered normal by his physician, then we would probably accept that.
Okay. All right. Thank you.
All right. Any other questions? If not, um, going once, going twice. All right. Well, we thank you for joining us on this warm evening. And we look forward to working with all of you as we move forward to improve the lives of our friends with Down syndrome and those of all of your families. And you guys are all pioneers. I want to actually emphasize that you have enabled us to make enormous strides. And without you and without your loved ones participating, we can't make advances in this. The treatment of all of the medical conditions of Down syndrome have advanced dramatically since I started in medicine in the 1970s. And the brain is the new frontier, right? We conquered most of the heart and managed most of the cardiac deficits. We're now moving towards the brain, and we've made enormous strides recently. And it's really high time that we brought our community of Down syndrome individuals into the fold of treatment for Alzheimer's disease. And I think it's pretty exciting days to conceptualize the idea of preventing this. In fact, one might argue that we might know more about prevention in Down syndrome of Alzheimer's disease than we will in the overall population if these studies work out. So very exciting times. I thank you for all your participation, and please reach out to us if you have any questions that come up. Kiara will post this video and the slides. Kiara, where will we be posting this? This will be on our YouTube channel and on our website.
Yes, the video will be on our YouTube channel, and the YouTube channel will be linked to our website, as well as we'll be emailing all of you the PowerPoint slide deck that we presented tonight.
Amazing. Have a
Thank
great
you all.
evening, everyone.
Thank you all.
Bye-bye now.
Thank you. So long. Okay.
Thank you.
Thank you. How do we do this? Sign off, leave.
All right. Well, I think that went very well, Kiara.
Yes, we have few people left on.
All right.
I can stop recording now.
Yes, I think